Good evening, and welcome to our webinar this evening. My name is Melanie West, and I'm the current chair of the ATA Board of Directors, as well as the acting executive director. I sincerely hope you are enjoying our 2016 webinar series. If you are, make some noise, and in a good way, and share them with a friend, a coworker, family member. They need to know what these conditions are about. Help others to understand the symptoms of tinnitus and hyperacusis and why treatment options are so important. Tonight, we will hear from two experts about tinnitus and pharmacology. Specifically, what drugs and medicines have been tried for tinnitus treatment, as well as what future drugs and medicines are being targeted to treat tinnitus. I want to be clear that ATA does not endorse or recommend any particular treatment or product. What you will learn tonight is for educational and informational purposes only and is intended to provide you with an overview of what types of drugs have been tried for tinnitus management and what we've learned from these trials. So please do not mistake the presentation for an endorsement of any kind or for any particular drug therapy. ATA remains committed to curing tinnitus by funding research, and in fact, one of our presenters this evening has recently been funded by ATA to look at new drug targets for tinnitus relief. So tonight's topic is particularly relevant to the research that ATA funds and believes is promising. We are fortunate this evening to have Dr. Michael Hoffer from the University of Miami Miller School of Medicine, who is also current member of ATA's Scientific Advisory Committee, and Dr. James Kaltenbach from the Cleveland Clinic, who is a former member of ATA's Scientific Advisory Committee, to share their expertise on pharmacology as it relates to tinnitus. I know I'm anxious to hear about it. I hope you are too. We also have Sal Gentile, an ATA member who will share his tinnitus experience, and Jennifer Bourne and Jody Asmus from the ATA staff who will be talking about ATA and helping to facilitate the webinar tonight. But before we begin, I'd just like to go over just a few housekeeping items as well as direct you to some of the functions that you'll be asked to use tonight during the course of the webinar. They're on your control panel. During the webinar, you will be asked to answer a poll. To answer the question, simply click your answer with your mouse, or if you are viewing the webinar on a smartphone or tablet, by using the touchscreen. If you are on a telephone, you will not be able to answer these questions. If at any time you lose audio connection through your speakers, please use the dial-in information provided in the email we sent. If you lose both audio and video connection, just click the link you used to join the webinar to rejoin at any time. If you experience any technical difficulties related to joining the webinar, please contact Citrix Customer Support at 1-888-646-0014. You may want to write that down, 1-888-646-0014. At the end of the formal program, there will be an opportunity for a question and answer period. If you would like to submit a question, please use your question feature in the control panel. We want to hear from you. Due to limited time, we'll not be able to have the opportunity to hear everyone's question. However, we want you to please submit. We will be able to use these questions in future webinars or in the Q&A column in our magazine, Tinnitus Today. I would also like to address some features in your control panel. If you actually as the attendee are in control of how you view the webinar. You have the ability to make the presentation full screen or not and control where you view the webcams on your screen. You may enlarge the screen by pulling down on the notched area on your screen or by pulling the corners of the video. When slides are being shown, the video of the speaker will automatically become smaller at the top. This you cannot control, but you will still be able to see the presenter and the slide. Please take a moment to familiarize yourself with these features. They will come in handy as the program progresses. Before we get to our pharmacology experts, I'd like to introduce you to Jennifer Bourne, ATA's Program Director. Jennifer has been ATA since 2006 and has worked for the organization in various capacities. I'd like to have her tell you a little bit more about ATA's history and programs. Jennifer?
Thank you, Melanie, and thank you all for joining us here this evening. As Melanie mentioned, I have been with ATA for nearly 10 years, and during that time, I have learned a lot from our members. Many of you in the audience here tonight, that medications for tinnitus is one of the most frequently asked about and frequently sought after pieces of information that people with tinnitus and hyperacusis ask about. Not only are you interested in what kinds of medications you can use to get relief from tinnitus, but you also have concerns about what drugs stay away from for fear of making your tinnitus worse. When ATA was first founded by Jack Vernon and Charles Eunice in 1971, these kinds of questions didn't have answers. This is precisely why, after establishing ATA, Jack and Charles made the decision to make both education and research founding principles of how ATA would serve the tinnitus patient community. Because of that, ATA has directly contributed hundreds of thousands of research dollars toward advancing science in the area of pharmacology. ATA's mission has evolved over the years, and recently our board of directors worked diligently on a new mission that encompasses more of what we heard our members telling us that they wanted from ATA. The mission guides everything that we do, and while being updated to reflect the current state of tinnitus research and treatment, remains true to the core principles that Jack Vernon and Charles Eunice envisioned for ATA in its humble beginning. If you haven't seen our new mission yet, it is as follows. The American Tinnitus Association, improving the lives of people with tinnitus and hyperacusis by providing hope of a quieter future through education, advocacy, and research toward a cure. I think you will find tonight's presentation particularly reflects that mission as well. As you know, the talks from our experts this evening will be focused on medications that have been used to treat tinnitus and their varying degrees of success, as well as possible future medications. Before we get to that, I just want to take a quick poll of our audience to find out what your experience has been with medications for tinnitus. And the question for the poll is, have you or do you currently take medications to help manage your tinnitus? And the answers are yes, a prescription exclusively, yes, a prescription and combined with sound therapy, yes, over-the-counter medications, yes, some other type of medication, or no, I do not use a medication to manage my tinnitus. And we will just give everybody a few seconds to lock in their vote so we can get a better idea of how much you already know about medications and tinnitus. There's been a great evolution in the science over the years, and I think that you will really learn a lot tonight about that. While we're waiting for the poll answers to come up, there we go. Okay, so just a few of you, a handful of you have had any experience with it. So I think there's a lot of education that'll go on tonight, and whatever your experience has been, I know that tonight you will learn much that you did not know before about this important, exciting, and hopeful area of research. Melanie, back to you.
Thank you, Jennifer, for that information about ATA's mission, evolution, which absolutely includes and will continue to include advancing research in the area of pharmacology. Now, I'd like to turn our attention to the main event. We want to get right to it. Our first speaker is Dr. Michael Hoffer. Dr. Hoffer has been working with tinnitus patients for 20 years. He is an otolaryngologist at the University of Miami Miller School of Medicine in Miami, Florida, and is affiliated with Naval Medical Center San Diego. He received his medical degree from the University of California, San Diego School of Medicine, and is board certified by the American Board of Otolaryngology, Neurotology, and the American Board of Otolaryngology. He is a current member of ATA's Scientific Advisory Committee and has expertise in tinnitus in military populations and comorbid conditions like traumatic brain injury. He will share with us information about what medications have been tested for tinnitus treatment and the varying degrees of success. It is my great pleasure to introduce to you Dr. Michael Hoffer. And Dr. Hoffer, he's setting up his slides currently, and we'll go ahead and have him come on webcam. And as you can see, I think the slides are showing well, so we're set up that way.
I'm sharing my webcam right now.
All right, there we go. All right, thank you, Dr. Hoffer.
Good evening, everyone. Thank you very much. We have quite a large attendance. I'm looking at the attendance ticker over here on the left, go up and up. So thank you for coming and sharing. For some of you in Florida and Ohio, your election evenings with us. I'm going to be speaking about what's been tried with respect to tinnitus pharmacology. Are my slides showing or not?
Yes, they're showing just fine.
Okay, no problem. As a matter of disclosure, I have nothing to disclose with respect to this talk. I will be discussing off-label use of medications, and the views expressed here are those of myself and not those of my department or the Department of Defense. Tinnitus is one of the most frequent medical conditions. 1/3 of adults have or will experience tinnitus. 10% of adults have consistent tinnitus, and 5% of individuals have disabling tinnitus. That means if you're in a group with 20 people, one of those individuals has disabling tinnitus, and 2 of them have consistent tinnitus, and probably 7 or 8 of them have experienced tinnitus. These percentages far outstrip other disorders that receive more attention and more funding. The treatment for tinnitus is basically consists of, first, if there's an underlying health condition, treat that condition. If there's no underlying health condition or if that has been treated, then we try noise suppression with white noise, hearing aids, or actual designed tinnitus suppression noise. Tinnitus retraining therapy is another option that we use. And finally, medications are used. And that's what we're going to focus our talk on tonight. The medications for tinnitus basically break down into several classes, and we'll discuss each of these classes in turn. There are benzodiazepines, antidepressants, anti-epileptics, and then a series of other medicines, zinc, ginkgo, and some new generation sleeping medicine. Benzodiazepines have a sedative, hypnotic, and anxiolytic effect. And the agents that you'll hear about or you may have tried include Xanax, Valium, Ativan, and Klonopin. Now, in common use, they're designed and used for anxiety disorders and insomnia, and therefore their side effects are drowsiness and some cognitive issues, and maybe an issue of dependency. It must be remembered that when you're on benzodiazepines, these medicines have a long half-life. So when you take this medicine now, you may be feeling the effects many hours later. With respect to tinnitus, benzodiazepines are used to reduce the anxiety that many of us feel associated with tinnitus. Now, there was one trial that showed some benefit using Xanax, and one trial that showed some benefit using Klonopin. These are both benzodiazepines. But most trials have showed no benefit. And unfortunately, several trials showed that a rebound effect was possible. So if you went off the benzodiazepines, your tinnitus worsened, certainly returned to where it was, and then worsened over time. Antidepressants are another class of medicines used to treat tinnitus. And there are a variety of medicines, all used to treat depression and other disorders. So they come from different classes of medicine. The ones you hear about are Celexa, Paxil, TCAs, SNRIs, like Cymbalta, Elavil for TCAs, and Trazodone. The main uses are depression, anxiety, and pain, but side effects include mania, restlessness, and mood issues. With respect to tinnitus, the antidepressants are used to combat depression associated with tinnitus. Unfortunately, these medicines have undesirable side effects, including dry mouth, sedation, and sexual dysfunction. And the Cochrane Review organization, which is an organization that reviews large combinations of studies, large numbers of studies, concluded that there is yet insufficient evidence to say that antidepressant drug therapy improves tinnitus in any way. Antiepileptic medicines are the third class of medicines we want to discuss for treating tinnitus. And all these medicines have anti-seizure effects. The medicines you may have heard about include Tegretol, Topamax, and Neurontin. And they're all used for seizure disorders, and some are used for bipolar disorders as well. Side effects include drowsiness, dizziness, mental slowness, eye issues, and liver issues, and these can be significant. With respect to tinnitus, these medicines are used because chronic pain, which these medicines are used for, is felt to be an analog of tinnitus. But to date, no trials have shown any direct benefit on tinnitus. Now, Topamax is effective in the treatment of vestibular migraine, in which tinnitus can be a symptom. So occasionally you'll be given Topamax to treat vestibular migraines, in which it has a proven benefit, and you'll get a tinnitus, a positive effect on your tinnitus. But that's only if you have tinnitus associated with vestibular migraines. New generation sleeping medicines are the next group of medicines we'd like to talk about. And these are used for the inability to initiate or maintain sleep. The agents you probably have heard about is Ambien and Lunesta. They're both advertised on television. And side effects include dream issues and dizziness. Now, they have no proven benefit with respect to tinnitus, but they can allow sleep if tinnitus is bothersome at night. And unlike medicines we spoke about earlier, these medications have a short half-life. So if you take these medicines to improve your ability to sleep at night, or if you need to get sleep because of the tinnitus, and wake up refreshed in the morning without a drowsiness, hangover, or side effect, obviously consult your physician before you start this kind of therapy. Zinc is a dietary supplement, an essential element for proper body function. It's actually used for just about everything. It's really only indicated if the total body zinc is low. And there's no proven benefits in trials for tinnitus, except for those individuals whose total body zinc is low, which is a relatively uncommon condition. Ginkgo biloba is another medicine that's used for just about everything. It's a Chinese herbal medicine with a variety of uses, including as a food source. It has some benefits for cognitive issues and for dementia, but no proven benefits for tinnitus. Now, none of the medicines that we spoke about tonight were designed for the treatment of medicine. And therefore, any medicine that you take for tinnitus likely will have more effects elsewhere than it will on the tinnitus, because it was designed to be working on another feature or elsewhere in the body. So that must be remembered when you take these medicines. That what you may perceive as side effects with your tinnitus medicine may actually be the effect of the medicine was intended to have. The fascinating array of medicines is because one single medicine does not work well for most individuals with tinnitus. So if we had one single medicine that worked, then we probably wouldn't have this long array or long list of medicines. But it's important to remember that what I quoted with respect to the use and disuse of medicines, or benefit or non-benefit of these medicines, are population effects, looking at large numbers of people. And despite these population results, individual patients may actually benefit from one of these medicines, one or more of these medicines. The frustrating thing is that the only way to tell if you're going to benefit from these medicines is a sort of a trial and error. Try the medicine, see if it works for you, see if the effects or side effects are tolerable. And this is a confusing and frustrating way of getting prescribed medicines for both patients and providers. I think that brings me to the end of my presentation, and I'll be able to turn it back over to Melanie.
Thank you, Dr. Hoffer. Sorry, we were taking care of a few technical things there while we were offline. But thank you, Dr. Hoffer, for such an understandable presentation about what drugs have currently been tried to treat tinnitus. I know that many of our audience members may have had or have had personal experience with some of the drugs you have mentioned, and I know they appreciate your overview of some of the concerns surrounding the varying degrees of success these drugs have in managing tinnitus. As we have just learned, while drug therapy remains a promising area of research and a viable possible future tinnitus treatment, currently there are concerns about all of the medications that have been tried for tinnitus relief. This is one of the many reasons ATA remains dedicated to funding research to find new tinnitus management strategies and to further optimize existing therapies. Dr. Kaltenbach is going to tell us about the current research he's been involved with. This is an exciting area. But before we get to that, and if you'll bear with us as we have a few technical problems every once in a while, I'd like to bring back Jennifer Bourne to tell us about ATA's history of funding research and why it's so important that we continue to fund research in the search for a cure. Jennifer?
Thanks again, Melanie. Since 1980, when we awarded our very first research grant, ATA has awarded over $6 million in what we refer to as seed grants to tinnitus investigators around the world. Our grant program consists of funding that is awarded to both researchers as well as to students to ensure the future of tinnitus research. Once the grants are received, a rigorous peer review process takes place by our esteemed Scientific Advisory Committee, a group of researchers and professionals from around the world, which, as evidenced tonight, is comprised of some of the most talented researchers who are looking to try and solve the tinnitus puzzle. Once those grants are received, a rigorous peer review process takes place. Each grant is evaluated through a set of criteria to determine its merit and its ability to push science forward. The proposal must also fall into one or more paths on ATA's Roadmap to a Cure, a document created by our Scientific Advisory Committee that outlines 4 paths of research, 2 basic and 2 clinical, that will ultimately help lead to new treatments and cures for tinnitus and hyperacusis. Once the grants are reviewed and scored, the top scoring proposals are then forwarded to our Board of Directors for funding consideration. As Melanie mentioned, all of ATA's ability to fund research comes from the generosity of our members and donors, which consist almost entirely of individuals. That is something that every ATA member can and should be proud of. So those of you here tonight who are ATA members, thank you for your support of the research that we have funded and for supporting our programs like these webinars. For those of you here tonight who are not ATA members, we invite you to join us. By becoming an ATA member, not only will you be supporting research, but you will also get the added benefit of seeing ATA's exciting 2016 lineup of webinars included in your membership donation. You will also receive Tinnitus Today, our magazine that's published 3 times a year, and it includes the most up-to-date information on research and treatment, questions and answers with tinnitus health professionals, and much more, all geared toward the tinnitus patient. We have included the most current issue of Tinnitus Today as a free download tonight. So if you go to the handout section in your control panel, you'll see a link, and you can click on that link at any time during the broadcast to download the PDF version of our most current issue. Membership is just $40 annually, and it can be done easily online at ata.org. We look forward to continuing to work together with all of you toward a future without tinnitus and hopefully without hyperacusis as well. Melanie, I'd like to turn the program back over to you to introduce our.
Well, thank you, Jennifer, for the valuable information that you share with us. I mean, you can see how rigorous the process is for these researchers to have grants approved, and the efforts that they make in submitting them and in volunteering their time, as Dr. Hoffer did previously, and now Dr. Kaltenbach will as well. So thank you, Jennifer, for your helpful information regarding ATA's programs. It is true that our members are and have always been the backbone of this organization. So I would also like to extend my thanks to each of you. Now we turn our attention back to the medicines for tinnitus. But this presentation will be focused more on the mechanics of what we have learned about drugs and tinnitus through research, and what the future holds in this burgeoning area of tinnitus research and treatment. For this presentation, I introduce to you Dr. James Kaltenbach from the Cleveland Clinic. Dr. Kaltenbach has been involved with tinnitus research since 1993. He received his PhD in biology at the University of Pennsylvania in 1984. After completion of his postdoctoral training in 1987, he joined the faculty of Wayne State University, first in the Department of Audiology and then in the Department of Otolaryngology in 1995. He moved to the Cleveland Clinic in 2008, where he serves as Director of Otology Research in the Head and Neck Institute and Department of Neuroscience in the Lerner Research Institute. He has also served on numerous committees at the National Institutes of Deafness and other communication disorders, the American Tinnitus Association, and the Association for Research in Otolaryngology. It is my complete pleasure to introduce to you Dr. James Kaltenbach. And Dr. Kaltenbach, I think we've got our slides ready and going, and we see you, and I welcome you to begin your presentation.
Thank you, Melanie, and thank you all who are joining us tonight. Thank you for your interest in the topic of neuropharmacology as it relates to tinnitus. In this presentation, I'm going to discuss the search for tinnitus cures in the laboratory, past, present, and future. I'm referring primarily to research that starts with testing of substances in animal models of tinnitus, and then from there the spin-off studies are the clinical trials. I'll start by giving a historic perspective of where this search has been in the past, where it has brought us to, and then I'll speculate a bit on how this search seems likely to unfold in the foreseeable future. My hope is that this presentation will give you a sense that research in this area has shown great progress, particularly in the last decade, and I'd like to summarize this progress with the hope that it will give people suffering from tinnitus a feeling of optimism that the study of tinnitus holds much promise for the future, that it holds much promise for the development of a cure for tinnitus in the years ahead. Just a couple of quick notes before I proceed. For those of you who may wish to read the script associated with this presentation, I have included the slide number both on the script itself and in the upper left corner of each slide. You'll frequently hear the term tinnitus as I go through these slides. Tinnitus simply means tinnitus destroying, tinnitus, and lytic, to break down or destroy. And this word is simply used to refer to treatments that have the effect of either reducing or abolishing tinnitus. And I use this term because it is far simpler than repeating the words anti-tinnitus agent or tinnitus-reducing drug every time I want to allude to those points. Okay, the search for tinnitus has a long history that dates back to at least the time of the early Egyptians. Documents from those times indicate that tinnitus was a problem that was treated by infusing various oils and other preparations into the ear, approaches which almost certainly provided little, if any, benefit. Despite their ineffectiveness, such practices continued to be used for most of the next 2 millennia. The major turning point didn't occur until the late 1900s, the 1980s and 1990s, when the first animal models of tinnitus were introduced. And the reason this was an important turning point was because the animal models allowed formalized study of tinnitus using the scientific method. The availability of these models has had a number of important effects that have propelled the search for the tinnitus cure forward. The most obvious has been the rapid surge in the number of scientific studies of tinnitus over the past 25 years. These studies have led to a better understanding of the cellular origins of tinnitus and its underlying mechanisms. This in turn has led to the identification of potential therapeutic drug targets. And with that has come an increase in the number of drug candidates that have been subjected to experimental tests in the laboratory. Many of these candidates have proven effective in reducing or eliminating signs of tinnitus in animals, and drug discoveries such as these, which have taken place in the laboratory, have in turn led to numerous clinical trials in human subjects. And these have begun to show some promise in certain subgroups of patients. Now, before I describe these drug candidates, I'd like to show you what tinnitus actually looks like and what it is about the auditory system that needs to be treated. On the left side of this slide, we see normal activity that is recorded when an electrode is placed in an auditory brainstem center of an animal with normal hearing. You can see a train of electrical impulses that occur at random. On the right side, however, you see what the activity looks like in the same structure of an animal that was exposed to an intense sound 1 month earlier. Here you can see that the impulses occur at a higher rate and their heights are larger. This greater degree of neural firing is what we refer to as neuronal hyperactivity. This hyperactivity is widely believed to be one of the key changes contributing to the emergence of tinnitus sounds, because it resembles the increase in activity that is seen in normal hearing animals when sound is presented to the ear. The neurons are literally behaving as though they are responding to sound even though there is no sound present. Where does such hyperactivity actually occur in the auditory system? This slide shows the areas of the brain where hyperactivity has been observed in animals and humans with tinnitus. As can be seen, the abnormality is not just at one level, but occurs in at multiple levels of the auditory system. The earliest stage where this activity is seen is down here in yellow in the nuclei called the cochlear nuclei. But we also see hyperactivity in the auditory midbrain, higher up in the pathway, in structures called the inferior colliculi, as well as in the highest levels of the auditory pathway where sounds are actually perceived. This is the auditory cortex. Now, as soon as this condition of hyperactivity was defined, scientists began asking whether it might be possible to turn down this hyperactivity pharmacologically and thereby abolish or at least reduce the severity of tinnitus. Now, after about a decade of research with drug effects in laboratory experiments, we can answer this question in the affirmative. But to understand why we believe this, we need to take a look at the current theory of what causes auditory neurons to become hyperactive in the first place. On the on the left side of this slide, we see a neuron that is in quiet, that it fires impulses only occasionally, as shown in the dark box at the bottom. This state of low firing is due to a healthy balance between two sets of inputs to the neuron from other neurons. One set is shown in blue. These are the excitatory inputs. By excitatory, I simply mean that these inputs cause activity to increase, that is, to be excited. If this were the only source of input, the firing rate of the neuron would be high. However, this excitatory input is counterbalanced by a similar share of inhibitory inputs shown in red. These latter inputs cause neuronal activity to go down, that is, to be inhibited. The result of this inhibition is to counter the increase in activity caused by the excitatory input, and the end result is a low rate of resting activity. This low resting activity is what a neuron would normally show in the absence of sound. Now, on the right side of the figure, we see what happens to a neuron after the ear has been exposed to too much noise. Here, the neuron shows a shift in the balance of these two types of inputs. Excitatory inputs, shown in blue, are greatly increased, while inhibitory inputs, shown in red, are greatly reduced. This produces a shift in the activity pendulum because there is now weaker inhibitory input and stronger excitatory input. The neuron shifts into a higher state of activation, causing it to fire more rapidly, as shown by the trace in the lower right. This is the condition of hyperactivity, and it is widely believed that it is what underlies tinnitus and what needs to be eliminated. With this theory in mind, scientists have entered the 21st century thinking about new and different ways to quiet neurons. They have developed two therapeutic approaches. The first works at the level of synapses. Synapses are the connections between neurons, and it is where neurons excite or inhibit each other. Studies at this level are performed with the goal of restoring the normal balance of excitation and inhibition that keeps neuronal activity low. The theory is that a healthy balance of these two input types could be restored by using drugs that either increase the amount of inhibition or decrease the amount of excitation. The other approach, the second approach, is to work at the level of ion channels. This approach bypasses the synapses and works right down at the level of the cell membrane where ion channels are located. Ion channels are critical to neurons' ability to fire impulses because they're the sites where electrical signals are actually generated. The next three slides summarize the results of these therapeutic approaches. The studies have identified no less than 11 drugs that work at the synaptic level, which show promise in experimental studies of abolishing tinnitus. Some of these drugs were specifically selected because of their well-known ability to activate inhibitory synapses, either directly or indirectly. 5 drugs, such as these that I show on the right, fall into this category, and all 5 have been found to have tinnitus-lytic effects in animals. That is, they abolish or reduce the severity of tinnitus. The other drugs were selected because of their well-known ability to block excitatory synapses, and 6 drugs fall into this category. They have all been found to be effective in reducing the severity of tinnitus in animals. In addition, some success has also been experienced in studies targeting ion channels. These drugs, 3 drugs, fall into this category, including lidocaine, reticabine, and OD3, shown here on the left. Lidocaine blocks sodium channels, and by doing so, blocks impulse generation and nerve conduction. 2 others, reticabine and OD3, promote the opening of potassium channels and therefore reduce activity by reducing the electrical excitability of the cell membrane. Now, putting all this together, you can see that we have a list of some 19 agents that have been shown to be effective tinnitus-lytics in animal studies. That is, they have been found to either reverse any behavioral or psychological measures of tinnitus in animals, or they reduce or eliminate the condition of neuronal hyperactivity, which I mentioned before is believed to underlie the tinnitus. There's also a new class of compound that has recently been discovered which prevent induction of tinnitus following noise exposure. These drugs have been found to protect animals from developing tinnitus after exposure to loud sound. Now, it is fair to ask, do any of these 19 agents that work in animals also reduce or eliminate tinnitus in human subjects? Well, in fact, six agents mentioned are still awaiting clinical trials in human subjects, so their clinical potential has not yet been determined. These are the ones that I show here on the left. 4 agents mentioned, which are shown here, cause dangerous side effects when administered systemically. The first one, vigabatrin, causes vision loss, while carbachol and lidocaine both have side effects on respiration and heart rate. These side effects greatly limit their clinical potential, meaning that they can only be studied. They can be used as experimental tools, and when doing so, they can be injected intratympanically, meaning that the drug can be given it can be injected into the ear cavity. When these agents are tested in this way, they have been found to have some efficacy in reducing tinnitus symptoms. Unfortunately, the effects are usually short-lived. Despite these shortcomings, the use of these agents has been extremely important in providing a proof of concept that it is possible to eliminate or reduce tinnitus by using drugs that target mechanisms suspected of causing tinnitus. 2 agents that I list here, first, ginkgo and gabapentin, have been tested in clinical trials but have yielded mixed results. Some studies suggest that these agents do not have any more efficacy in humans with regard to tinnitus than a placebo. Gabapentin works in a subset of patients with tinnitus suffering from vascular compression, but not in the larger population as a whole. Another agent, amantine, failed to show evidence of a tinnitus effect when taken orally. The 3 others that I list here have been tested intratympanically, primarily as an experimental tool, and they have shown tinnitus effects, but the effects of pilocarpine and gacyclidine were generally short-lived, only 72 hours or less. The most striking effect was achieved with this drug AM-101, where the tinnitus effect actually lasted up to 90 days. So is this the magic bullet we've all been waiting for? We're all paying close attention to the follow-up studies with this drug, and it remains to be seen, but there is great interest in it. Now, in view of these accomplishments, what can we expect to see on the tinnitus horizon in coming years? We should expect to see clinical trials with agents that show efficacy in animal studies. In particular, look for studies of NMDA receptor antagonists such as ifenpridil or AM-101, which I just mentioned. We hope also to see follow-up trials with taurine and sildenafil, both of which completely or nearly completely reversed tinnitus in animals. And we should be hearing more about potassium channel promoters, retigabine and EGB-761, as preventive agents that protect against the damaging effects of noise exposure. Lastly, we can expect to see an increasing effort to define drug targets that do not cause major side effects when activated. You should stay tuned for more about cholinergic receptors that go beyond the unsafe and dangerous drug carbachol, which I referred to earlier, which targets all cholinergic receptors. Studies presently underway are examining effects of drugs that are selective for individual subtypes of cholinergic receptors. These have the potential to be far superior to carbachol because some of these subtypes are found in more restricted areas of the brain and body and therefore do not have the powerful effects the powerful side effects on the heart and or respiratory system. These drugs are likely to have far fewer side effects than the more generally acting drug carbachol. We should also look forward to hearing more about the effects of potassium channel modulators such as OT3, which has been shown to reverse tinnitus in animals. I'd like to summarize by making a few statements. We have more knowledge than ever before about tinnitus, about the mechanisms and its substrates. Numerous drug candidates have been introduced for use in animals that are awaiting clinical trials. New drugs with more specificity are likely to be introduced in the near future that offer hope of relief from tinnitus with reduced severity of side effects. At some point in the more distant future, we can expect improvements in pharmacotherapy that will reduce tinnitus symptoms with minimal side effects. But because tinnitus, by its nature, has multiple mechanisms and multiple causes and profiles, it's reasonable to expect new drug therapies to be effective for specific subgroups of tinnitus sufferers who share common causes and symptoms, rather than for the whole diverse patient population as a whole. In other words, progress is likely to be gradual, affecting small subsets of patients, but gradually expanding as we go forward with the addition of each new drug. That size of the population that will benefit from tinnitus pharmacotherapies will increase with time. So I'll stop there. Thank you all again very much for your interest in this subject and for attending tonight.
Well, and thank you, Dr. Kaltenbach, for that encouraging presentation outlining in a very easily understandable, and it's a very complicated subject for both of you, but we appreciate you taking the time to make it understandable for us as much as it can be, outlining what areas of the brain are being treated for tinnitus drug therapy. Clearly, research has been made and shows some excellent progress in this area, and all of us in attendance tonight have hope for a possible future medication to treat tinnitus. I'm sure trials will be in place in the future. And one of the ways we're going to affect change is to make some noise to silence tinnitus. And when I say make noise, in a good way. Share your story of tinnitus or hyperacusis with your doctors and your congressional representatives. Encourage them to vote for more funding towards tinnitus and hyperacusis research. And now we're going to turn our eyes a little bit differently. We now have an ATA member who is willing to share his story in the same way that we'd like you to share yours. Someone who has been through the trials of tinnitus and who has turned adversity into positivity. While it's true that some people with tinnitus still haven't found a treatment or therapy that works to help them, there are some who have, and we want to provide those stories to our audience to provide information that can help you as well as provide hope. I'd like to introduce Sal Gentile, a retired IBM executive who is also an ATA member, support group leader, fundraiser, and avid bicyclist, to share his journey with tinnitus with all of you. Sal?
Well, thank you, Melanie, and thank you all for listening. I've been challenged with tinnitus and hearing loss for the last 4.5 years. It started while celebrating my birthday. I recall being out with friends at a noisy restaurant. That night I could not sleep because I was hearing all of these noises in my ears. The next morning I awoke to the sounds of horrible noises that were certainly worsened. I seriously considered calling 911, thinking I had some sort of a brain injury. I couldn't get out of bed and stayed there for a few days before realizing I got to get some help. Previously, I had been on antidepressants for general anxiety and panic disorder. I had successfully weaned myself from them, and I thought I was having a relapse. I went to my regular doctor, and he diagnosed me with an anxiety attack. After seeing a dozen health professionals, the message that came across loud, clear, and cold was, "You have tinnitus. You have to learn to live with it." But that just wasn't good enough for me. I wanted my life back. My psychiatrist insisted on putting me back on antidepressants, but I refused. I wanted to keep moving forward. I didn't want to go backwards. I then found the American Tinnitus Association. I became a member and used their website to identify a seasoned audiologist and assistant professor in my geographical area. I spent 4 hours with him and was diagnosed with high-frequency hearing loss and tinnitus. He taught me how to disconnect from the noises by using sound therapy and white noise. I immediately ordered a pair of hearing aids with amplification and sound. To further deal with the anxiety I was experiencing, I also started keeping myself busy by taking very long walks, spending long hours at the health club, and doing what I enjoy most, long-distance bicycle riding. I continued my yoga, my cognitive behavioral therapy, and mindfulness meditation instead of antidepressants, which I really feared might interfere with the progress I was making. Sound machines were placed in each of the rooms of my home, and I used what's called the sound pillow system to sleep. My wife was there to support me along with my 2 rescue dogs. I slowly began to socialize again. I knew I was on the path of habituation. As part of this, I wanted to give back and help others, so I became a volunteer for the American Tinnitus Association. I started a support group here in the Tampa Bay, Florida area where I lived, and now one in the Villages, Florida, where I live. I also became involved with the Tour de Tinnitus bicycle ride. This is an annual fundraiser for ATA. I raised well over $20,000 on 2 tours and organized an event that raised approximately $6,000 in one evening. Being a volunteer for ATA and helping others with their tinnitus has really been instrumental in helping me manage my own tinnitus. In closing, I want to leave you with the saying that really has helped me in my tinnitus journey. Life is 10% of what happens to you and 90% of how you react to it. This is true with tinnitus as well. If you are struggling with your tinnitus, find something to take your mind off of it. Join a club, start an exercise regime, or just volunteer. But don't be passive about your tinnitus. Make some noise about it in your community. In my experience, it has changed my entire perspective on living with this condition.
Well, Sal, I want to thank you truly for sharing your story. It's not that easy, but that's what we each need to do, is to get out there and share our stories with others. I'm shocked at how many people don't know about tinnitus or hyperacusis, and so we haven't reached the public at large. So thank you for sharing your experience, and thank you for what you've done for ATA. I know those that are just some of the many contributions you have made to ATA, just to name a few, and the tinnitus community. So thank you for making noise about your tinnitus in a very positive way. And now it's time for the question and answer portion. We're going to ask each of you, each of the speakers and our member highlight to come back on with Jody and Jennifer, and we're going to answer the questions that you've sent in. Some of these most of these we received, and some of them we received previously, so we're going to address them. I'm going to start right in so that we get to many of the questions. Let's see, this one was directed, many states have legalized medical marijuana, and several states have legalized it for recreational use. Has anyone ever reported if using marijuana will reduce my tinnitus? Dr. Hoffer, I'm going to let you, if you can, take that one.
Yes, it's actually a mounting body of evidence that cannabinoids, which is a part of the marijuana plant, not the part that makes you high, have neurological benefits in use in epilepsy and in some dementia trials. It has not yet been tried for tinnitus, but there are 2 trials on the horizon, so we will see what those trials bear out.
Okay. And Jennifer, this one was actually directed to you. It's a question for ATA. Why haven't the big pharmaceutical companies come out with a drug that treats tinnitus, and does ATA ever communicate with them to find out if they are working on it?
That's a good question, and something that we're all asking in ATA too. I can tell you the answer is yes. ATA has communicated with some of the big pharmaceutical companies and also some of the smaller ones over the years. I've definitely been part of those meetings during my time at ATA. I think the reason that we don't have something yet is because of a lot of what we learned tonight from Dr. Kaltenbach's presentation and some of the other research that's been out there, is that the groundwork to understand the mechanisms responsible for tinnitus generation and maintenance were not fully understood yet. And so those pharmaceutical companies want to have that kind of information before they jump in feet first to develop a drug for tinnitus. Now that we have that kind of research, we best believe ATA is going to make sure that we make some noise about tinnitus to these types of corporations and to these people who can help advance the science in this area.
Thank you, Jennifer. And this next question is one I hear often. Dr. Kaltenbach, when Sal was talking about anxiety and some of the problems, this person is asking, anxiety is my biggest problem. I was not an anxious person before the tinnitus. Will anti-anxiety pills make the tinnitus worse?
Well, of course, I'm not an MD, so I don't have a lot of experience with that. But you know, it's difficult to generalize. There certainly is potential for side effects that could include tinnitus, depending on the individual. Generally speaking, you know, these drugs are designed to reduce the anxiety. But that's not to say that they necessarily reduce it by reducing the loudness of the tinnitus. They basically are targeting the emotional reaction to the tinnitus. So could that make the tinnitus worse? It could. I'd like to hear Dr. Hoffer's take on this too. But if it does, then the obvious response to that is to stop taking it. And you know, if you're working with a physician, the physician can guide you. Perhaps try an alternate anxiolytic, but it's never good to work on your own with these things. You get a prescription, try it, it doesn't work, or it makes it worse. That doesn't mean you should completely give up with that category of drug. There's still possible alternatives. Dr. Hoffer, what do you think of that?
Well, there are some individuals who are made very anxious by their tinnitus, and so the goal of using anxiolytics is to reduce the anxiety or the response to the tinnitus. And sometimes that works and sometimes it doesn't. Oftentimes I will refer people to my mental health colleagues to work on that aspect, because as an otolaryngologist, I don't have as much experience with those medicines as some of my colleagues do. So if you're working with an otolaryngologist or an audiologist, you might want to seek help from mental health if anxiety is a big issue with your tinnitus.
Okay, here's another good question. A gentleman asked, I have read that Briviact, an epilepsy drug, may be helpful for tinnitus. What is your opinion of Briviact treatment for tinnitus? I don't know if I'm pronouncing that correctly, Dr. Hoffer, but would you take that one?
It's kind of interesting because that one I would probably ladder to Dr. Kaltenbach, which I will do in a minute. I don't have much experience with that particular medicine, although I certainly know that some of the anti-epileptic medicines are being used with none having any proven benefit in trials. But Jim, I don't know if you have any thoughts on anti-epileptics.
Well, the only I can say that, just to add to what you've said, you know, the anti-epileptics have been used in animal studies. Retigabine is the one that comes to mind immediately, which I referred to in my presentation. It doesn't seem to abolish tinnitus in animals, but what it does do is it prevents the development of tinnitus after the animals have been noise exposed. So if the animals have received a dose of retigabine, an anti-epileptic drug, they not develop tinnitus compared to the control animals, which may have received either nothing or an injection of a neutral solution.
Okay. And we have time for one more question. I know there's always more answers, so I don't mean to cut you off, Dr. Kaltenbach, but these are deep subjects. They take a lot of explanation. But we only have time for one more question. If your question wasn't answered, please be sure to attend the next webinar, as it may be one that is answered by another presenter or speaker, or we may use them in future issues of Tinnitus Today, so take a look there as well. So here's the question. Many times people think, give me a pill and make it go away. This question I hear again very often. I know that there are drugs being tested for intratympanic delivery as well as those in pill form. What are the benefits and disadvantages of each of these kinds of drug deliveries? Now, would you first explain what intratympanic delivery is for everyone? Dr. Kaltenbach, we'll start with you.
Okay. Well, intratympanic means into the ear. So tympanum is the Latin term for the ear. Usually it's intratympanic cavity, the middle ear part of the ear. So it's literally injected into the middle ear. And then from there it can diffuse through the membrane that separates the inner ear from the middle ear, and where it can actually do its work. Yes, we are seeing a number of studies showing effective tinidolytic effects in both animals and humans when these drugs are given intratympanically. And most of these studies are done in humans, but some have been done in animals as well. That have actually been done first in animals and then in humans. So yeah, the studies that have been published look promising. They seem to have significant effects. But as I said in my presentation, the effects are, for the most part, are short-lived, less than 72 hours. This one drug, AM-101, has a 90-day or more effect. So that's the one we're all eyes are on that drug right now. It's trying to see whether that's going to hold up with repeated study, but it certainly could end up being an extremely important drug in the armamentarium of tinidolytics going forward.
And Dr. Hoffer, any comment on that question?
Dr. Kaltenbach did a nice job explaining it. There is an essential distinction between an intratympanic medicine and a pill. An intratympanic medicine, if it works, will have local effects and less systemic side effects. Even if we don't find a medicine that was designed for tinnitus, it would have some systemic effects. By injecting it into the ear, you avoid that. But you also have to basically be seeing a physician capable of delivering that medicine. You have to have the medicine injected through your eardrum, whereas a pill you could take every day at home and not have to go through the injection. So there's pluses and minuses of each technology, and as we develop more drugs, we'll see which drugs work with which way.
All right. Well, thank you both for taking your time tonight and speaking, and also Sal Gentile. I want to thank each of you, Jennifer and Jody, for presenting and helping with the backside of things. I mean, this doesn't come on your screen very easily sometimes, and we have some technical issues we have to deal with, but we work through them. So I want to thank you each for attending our webinar tonight on pharmacology. There's other questions. In fact, one of them I'm going to throw out is, how close are we to having a drug for tinnitus treatment? Well, we're going to have to put that one in Tinnitus Today or one of our other future webinars, because there's just so many questions that we have that ATA wants to answer. Bring those specialists to you that maybe can give us the answers. So I hope you learned as much as we have tonight, and that you've taken away from this webinar all the concerns with existing tinnitus drug therapies, as well as the hope for the future of a tinnitus medication. As stated, there are some concerns and, again, cautions with existing tinnitus drug therapies, but there are great hopes for targeted pharmacological treatments and medication for tinnitus in the future. Our next webinar will be on May 17th, 2016. It will be on hyperacusis, and that is sensitivity to normal sound. for those of you who don't know, hyperacusis is an extreme sensitivity to everyday normal sounds that can cause physical pain in severe cases. That webinar will feature Dr. Richard Salvi from the University of Buffalo and Brian Pollard, an ATA board member who suffers from hyperacusis and who is the president of Hyperacusis Research, an organization he founded after he and his wife both developed hyperacusis to help prevent further research in this condition. So hyperacusis is common in tinnitus patients, and recently ATA has incorporated hyperacusis into its mission statement since there is a high correlation between the two conditions. Registration will be available for that webinar soon at ata.org. ata.org. But attendance is limited, so register early. In the meantime, go to ata.org and check out the list of speakers for 2016 or refer to the back page of Tinnitus Today. If you're not a member, please consider joining and enjoy these valuable benefits. Also, I want to thank our presenters again, Dr. Michael Hoffer and Dr. Jim Kaltenbach, for volunteering their time and expertise tonight. We are truly fortunate to have had them here and to share their experience and important research and information in this area. Again, thank you, Sally Gentile. We appreciate it. Thank you, and join us again. We hope you have a good evening. See you in May. Good night now.
Good night.